Hey everyone, welcome back. So today we're going to talk about how someone who practices behavioral activation might work with someone that is OCD, Obsessive-Compulsive Disorder. So behavioral activation, BA, is an evidence-based treatment primarily for depression, but its principles, particularly regarding the avoidance-behavioral cycle, are highly relevant and can be adapted to treat Obsessive-Compulsive Disorder, OCD. While exposure and response prevention, ERP, is considered the gold standard for OCD, BA shares significant overlap with the exposure aspect of ERP and can be a valuable component or foundational approach, especially when depression co-occurs with OCD or when addressing the behavioral avoidance inherent in compulsions. The core idea of behavioral activation for OCD is that compulsive behaviors are a form of avoidance. And this avoidance, while providing short-term relief, maintains the obsessive-compulsive cycle by preventing habituation and new learning. The goal of BA is to break the cycle by increasing engagement in meaningful activities and decreasing engagement in compulsive or avoidant behaviors. Here's how a behavioral activation therapist would treat OCD. 1. Understanding the OCD cycle as avoidance. The therapist educates the client about the OCD cycle. Intrusive thoughts, the obsession, leads to anxiety or distress, which leads to compulsive behavior, which leads to temporary relief, which leads to increased belief in the necessity of the compulsion. Crucially, they frame the compulsive behavior, physical or mental, as a form of avoidance. It's an avoidance of distress, uncertainty, contamination, harm, or other feared outcomes. The short-term avoidance prevents the client from learning that the feared outcome won't occur, and that they can tolerate the distress without performing the compulsion. They emphasize that stopping compulsions, reducing avoidance, is key to breaking the cycle and allowing for new learning. 2. Activity monitoring and identification of avoided activities or compulsions. The client is asked to track their daily activities, including obsessions, what intrusive thoughts, images, or urges appear, anxiety, distress levels, how intense is the distress associated with the obsession, for example, on a 0 to 10 scale, compulsions, what specific behaviors, checking, washing, rearranging, rereading, mental rituals, reassurance seeking, are performed in response to the obsession, and avoided activities. What valued activities or situations are the clients not doing due to their OCD? For example, going to public places, touching certain objects, leaving the house, engaging in hobbies. Purpose: to create a clear map of the client's OCD patterns, including the triggers, the distress, the compulsive responses, and the broader life avoidance. 3. Values clarification. The therapist helps the client identify their core values: health, relationship, productivity, freedom, spontaneity, learning. Purpose: this is vital. OCD severely limits a person's life and prevents them from living in line with their values. By clarifying what truly matters, the therapist helps the client identify meaningful activities to engage in, which provide strong motivation to resist compulsions and face fears. For example, if a client values connection, but their contamination OCD prevents them from socializing, the therapist links the activation of social activities directly to this value. Graded activity scheduling, targeting compulsions and valued living. This is the core of BA. The therapist and client collaboratively schedule specific activities into their routine. These activities will focus on 2 main areas: directly reducing compulsions, behavioral inhibition, response prevention. This is where BA heavily overlaps with ERP. The therapist helps the client create a hierarchy of feared situations or thoughts and gradually engage in them without performing the compulsion. Graded steps: start with a small, manageable step. If the client has washing compulsions, the first step might be to touch a slightly contaminated item and delay washing hands by 1 minute, gradually increasing the duration, intensity of contamination or variety of items. Specific and concrete: touch the doorknob and wait 2 minutes before washing hands rather than stop washing so much. Focus on response prevention. The activation here is activating an alternative behavior, tolerating distress, engaging in another activity instead of the compulsion. Increasing engagement in valued activities, counteracting avoidance. These are activities the client has stopped doing or wants to start doing, but their OCD gets in the way. Pleasurable activities, re-engaging with hobbies or leisure activities that OCD has taken away. Reading a book, going for a walk in a feared area, meeting a friend. Mastery activities, tasks that provide a sense of accomplishment or competence, for example, completing a chore without rechecking or starting a new project or working on a skill. Social activities, for clients whose OCD leads to social isolation, for example, fear of contaminating others or social anxiety in rituals. Key principles: action over feeling. The therapist repeatedly emphasizes the client must do the scheduled activities and resist the compulsion despite the anxiety or discomfort. The reduction in anxiety and the increase in positive reinforcement from living out values will follow the action. 5. Troubleshooting barriers to activation compulsion prevention. The therapist anticipates and helps the client problem solve common obstacles. Intense anxiety. Acknowledge the anxiety, but encourage the client to ride the wave of discomfort without performing the compulsion. Reinforce that anxiety naturally decreases over time when the compulsion isn't performed. It's habituation. Negative thoughts and beliefs. Well, BA doesn't directly challenge thoughts like CBT. It encourages the client to act opposite to the thought. The behavioral experiment of not doing the compulsion provides evidence that the feared outcome doesn't occur or is tolerable. Just right feeling. For compulsions aimed at feeling just right, the therapist helps the client tolerate the not just right feeling and proceed with a non-compulsive activity. Safety behaviors. Subtle compulsions. Identify and work to eliminate subtle compulsions that our client might not recognize. For example, excessive mental reviewing or reassurance seeking from others. 6. Monitoring reinforcement. Clients continue to track their obsessions, anxiety levels, and whether they perform compulsions or engage in scheduled activities. The therapist reviews the data, celebrates instances of resistant compulsions and engaging in valued activities, and highlights the resulting reduction in distress or increase in life satisfaction. This reinforces non-compulsive behaviors. Relapse prevention. As therapy progresses, the therapist helps the client consolidate their learning. They develop a plan for managing future intrusive thoughts or urges, identifying potential triggers, and committing to continued resisting compulsions and engaging in valued living is a primary strategy. The focus is on embracing uncertainty and tolerating discomfort. I hope you found this helpful. Let me know your thoughts in the comments, and I'll speak to you next time.